Very good. Thanks. Still getting used to all of this, guys. Thanks for joining me tonight. And thanks for Kathy for putting this together, as well as the Gildenhorn Institute at Sibley Hospital. I hope you guys get something out of this tonight, and there'll be a question session at the end, and I'll be happy to answer anything you guys ask. We're going to talk about what's new in hip and knee arthroplasty. Obviously, I haven't updated my first slide, so we're in 2021 now. Time stands still with the COVID pandemic. Still, most patients are want to talk about the elephant in the room. We're fortunately getting a pretty good handle on COVID throughout America, and so this is, ever changing. But vaccines have been fantastic so far. A lot of patients, especially over 65, are either partially vaccinated or fully vaccinated, and now looking to have surgery again. Some patients are asking about surgery timing as it relates to vaccines. There's really no right or wrong answer. Most patients are waiting, and since the time frame is pretty much now for vaccines, that's really not an issue for people. We're still testing everyone that comes into the hospital. I think that's still important, even though the vast majority, if not almost everyone that works in the hospital, is also fully vaccinated. The family visitor policy keeps getting updated, and as the numbers come down, that's going to hopefully trend back towards normal and allowing family in the hospital, during the procedure and during their stay. Fortunately, there's been virtually no transmission within the hospital, even though we've been doing elective joint replacement now pretty much full tilt since June of 2020. Physical therapy, there were questions about that, has also been quite safe, although there also are some virtual options, and we've utilized home therapy a little bit more frequently to minimize patients being out and about. We'll also talk about outpatient surgery again in a minute or here, but that also has become much more prevalent, especially with the pandemic. Patients have wanted to come in and not stay overnight, and we can talk a little bit more about that in a minute. So this is an article I published a couple months ago. This has been probably the biggest change in joint replacement in the last 10 years, has been the shift from hospital stays to what I call same-day discharge arthroplasty or joint replacement. It's COVID and the pandemic only accelerated this as patients more and more wanted to minimize their time in the hospital. It's been proven to be safe for selected patients. I think it's important that you have criteria for patients that can be safely done and discharged the same day. They generally need to be very healthy. They typically need to have good social support, and obviously they need to be interested in going home the same day and motivated. It does lead for potential for faster recovery and potentially higher satisfaction rates in some of the early studies, and there are typically cost savings for the patient and the system in general. There's a podcast I did for this article also that can be found on my website if you want to listen to that. So we'll start with a little bit of background on hip and knee arthritis and replacement. Some quick questions. How many people in the United States undergo hip and knee replacement surgery each year? That number keeps increasing, and now it's about 1.3 million hip and knee replacements are done every year, which is pretty amazing. And then what is the leading cause of disability in the US? And it's not heart disease, it's not diabetes, it's actually arthritis. So let's talk a little bit about what arthritis is. Essentially, where there are two general types of arthritis, we're talking about the standard wear and tear osteoarthritis, which is what makes up the vast majority of arthritis at this point. And that literally is just describing the cartilage that lines the end of the hip or the knee or really any joint just wears away. It breaks down. It doesn't repair itself, and with time it progresses. Essentially, you can progress all the way to what's called bone-on-bone arthritis, where the cartilage is gone, and the more exposed bone, the more pain patients typically have. There also are inflammatory arthritis, which are things like rheumatoid arthritis or psoriatic arthritis. This is an autoimmune disease where the lining of the joint or the body actually attacks the cartilage, and it presents a little bit differently. And frankly, we don't see it nearly as often as we used to, because the medications used to treat these diseases are so good. So the treatment pathway, like most things, we generally start with non-operative treatments, things like diet, exercise, physical therapy, bracing, medications, injections, and then ultimately, if those fail, we progress on to surgical treatments, which can range from arthroscopic debridement, which we don't typically do for arthritis much anymore because the results have been really hit or miss, to osteotomies where we realign the joints, to what you guys are tuning in for, joint replacement, which again is quite common. We're going to mainly focus on surgical interventions tonight and the new things that are going on with surgery. Some basic background, just so you understand what a hip replacement is. There are 4 components listed there. There's a stem that goes down into the femur after you remove the femoral head or the top of the femur bone. That generally is wedged in and the parts are grown on. Sometimes we cement those in. On the end of that, you can see the pink ball on the diagram there. On the socket side, there's a titanium cup that's placed. It's wedged in and the body grows onto that part. And then there's a liner placed inside of that. It's typically plastic. And those are the 4 components of a hip replacement, and that's pretty much what it looks like. Again, we're removing the diseased parts of the bone and replacing them with essentially metal, plastic, and ceramic at this point. Here's some diagrams showing a healthy hip, what arthritis typically looks like, and then what it looks like after it's replaced. Bearing surfaces. This is not quite as new of a topic. It was has historically been a hotter topic, and the pendulum has almost come full circle at this point. Most replacements now are going to be a ceramic ball with a modern plastic socket or liner with a titanium cup. There are other bearing surfaces like the bottom left, which is a metal ball and a metal liner. Those were popular about 15 to 20 years ago, and unfortunately, they had pretty poor results, and some of them, the implants were recalled. You're not going to see those on the market anymore. On the bottom right, those are ceramic on ceramic parts. They have the best wear characteristics of any of the materials, but the ceramics, while they're still incredibly good, there's a small risk of ceramic fracture and even squeaking where they can make noise. And generally, we only consider those in patients very young, usually under 30 or 40 years of age. The new plastics are wearing tremendously well. We are not seeing the problem with the plastics that we were seeing in the 80s and 90s. To give you an idea, most of the wear rates now, the plastics are wearing less than 0.01 or 0.02 millimeters a year, which is pretty fascinating. Talk quick about the Anterior Approach. Again, this is a newer approach. It's been out now for 15 to 20 years. It's not brand new, and you're seeing this more and more commonly done as surgeons are coming out of training, trained on it. Compared to the traditional approaches, in my opinion, there are 3 major benefits compared to the posterior or the lateral approach. Number 1, we don't cut any muscles coming in from the Anterior Approach, so patients generally recover faster, which has been proven. The second benefit is it allows me to do the surgery with the particular technique I use with patients on their back rather than on their side, which allows me to use imaging during the operation. So it makes me more comfortable, more accurate with where we place the components and sizing, and can even measure leg lengths. The third benefit is because we don't violate any of the structures in the back of the hip, the risk of dislocation is also lower, which allows patients generally not to have precautions, which is a major benefit. And again, this is the traditional position when you come in from the back or the side. There's a little cartoon here I'll play. This is a diagram. Incisions in the front of the hip. We go between 2 of the muscles in the front of the hip, and you're right down at the hip joint. And then voila, hip replacement goes in. It's a little bit more work than the video makes it seem, but kind of gives you the view that we have. I use what's called a HANA table, which facilitates the approach, makes it a little bit easier on the surgeon, and makes the exposure easier. Again, the benefits of the anterior approach, generally it's going to be a little bit less trauma to the body. It can be a smaller incision. There may be less pain, possibly a faster recovery. Generally, I don't give patients restrictions after an anterior approach. The X-ray assistance definitely helps with component positioning, and generally it's been found to have a lower dislocation risk. So let's talk about knee replacement. Again, we'll start with what it is. The way to think of a knee replacement is it's really a resurfacing. You've worn the surface of the knee out, and we give the knee a new surface. So you make small cuts on the tibia and the femur bone. You remove a few millimeters of bone, and you recap it or resurface it with a piece of metal. There's generally a piece of plastic in between the two pieces of metal, and there's often a piece of plastic on the back side of the kneecap. We'll talk a little bit about materials and designs going forward. So overall, knee replacement has been a very successful operation. It's generally quite reliable at providing excellent pain relief and generally improved function. However, approximately 10 to 15% of patients are not satisfied with their knee. That generally means that if you look at objective scores, almost everybody with a knee replacement, their scores greatly improved, but for whatever reason they are not satisfied, which leaves room for improvement. And this is where some of the technological advances are coming in play, and hopefully will lead to even better outcomes. So why are patients unsatisfied? And it's probably multifactorial. Is it implant motion? Is it the fact that they either don't achieve full range of motion, or is it the quality of the motion, how the motion feels, or what we refer to as joint balance? Because it has to do with fit of the implants or sizing, or is it something with patient expectations, or surgeons not doing a good job setting appropriate expectations and trying to describe what a patient will experience afterwards? It's probably a combination of these. So some of the newer technologies for knee replacement, we'll talk about a custom knee replacement, we'll talk a little bit about robotics, and we'll talk about some ligament sparing designs. So what is a custom knee replacement? The word gets thrown around a lot. There really is only one true custom implant on the market right now, and it's by a company called Conformis. And essentially what they do is they use a CT scan and they ship it to the company, and the company digitally performs the surgery and then builds an implant unique and specific to the person's knee. They also build the implants, which are the jigs that we use to put the implants in. Those are specific to the person. They sterilize it all as a package, ship it to the hospital, and we put it in. No two implants are alike, neither are the jigs. The jigs are disposable. Sometimes what is called patient-specific instrumentation will be called custom replacements. And really that's a customized plan for the surgery, but the implants are not unique to the person. The jigs or the instruments we use are customized to the person. And that has some benefits, but it's not quite the same as a full customized replacement. Most of the all the other implants on the market are what we call off-the-shelf implants. It's kind of like shopping for a shoe. Lots of different sizes. That's one of the advancements we've had over the last few decades, is the companies have come out with a lot more sizes, which makes us better, more and more accurate with fit for patients, but it's not a custom implant. Again, this is designed for the patient's anatomy. It generally allows you to remove a little bit less bone, and it minimizes the amount of soft tissue dissection that has to be done generally. We're still waiting on outcomes, long-term, medium-term, to see whether this translates into improved outcomes or patient satisfaction. Like most technologies in joint replacement, these lag quite a bit because overall joint replacement is so successful that we don't measure outcomes in weeks or days or months or even years. It's often decades, and so it takes a while to accumulate this data. Hopefully we'll be learning more and more about this going forward. Robotics is a really hot topic. It has been for a number of years. There are now multiple robotic systems on the market. They can be image-based or they can be image-less. What that means with the image-based systems, often we'll get either special set of x-rays or CT scan or MRI prior to the surgery, and the robot will incorporate that information in to help put the implants in place. Imageless means that you don't need special imaging before surgery. We gather the information we need during the operation, and the robot incorporates that in to the surgical plan. These still use off-the-shelf implant. They're not compatible with a customized implant at this point. And the robot assists with making the cuts, which hopefully leads to more accurate and more precise cuts. It also gives you feedback, digital feedback on the motion of the knee, which is quite helpful in helping us hopefully achieve better balance for the knee. Again, outcomes at this point have not shown significantly improved outcomes for patients, but it's still pretty early with the data. So as we get more years of experience, we'll learn a little bit more about whether or not this changes patient satisfaction or functional outcomes. A little bit more out there at this point are what's called a bicruciate retaining knee replacement. What that means is there are two ligaments in the middle of the knee, the anterior and posterior cruciate ligaments. For standard or traditional knee replacement, either one or both are sacrificed or removed. This is not a new concept. It's been out since the 70s. And the reason this is not called on over the years is it's a quite technically demanding operation, and the failure rates were higher. There are some newer versions out that potentially look promising. Again, the data is very short term. And we also think that possibly coupling this with some of the robotic technologies may make the technically challenging surgery more reproducible. One of the other issues is a lot of times patients who have severe arthritis in the knee, they don't have normal ligaments, or the ligaments have already been torn. And so I doubt all patients will be candidates for this technology, but it is something potentially to keep an eye on going forward. And so those are the current kind of hot topics and latest information. I can go in more detail with questions, and I'm going to open it up to you guys tuning in. I hope that was informative and answer some of your questions. Kathy, how are we going to do this? Are they going to come in questions?
I think if everybody will type their questions into the Q&A, that'll be the easiest way to keep track of them and which ones have been answered. So if everybody doesn't mind doing that, that would really be the easiest way. And okay. Again, I see one in chat, but if you could transfer it over into Q&A, then we're only looking in one spot. That'll be helpful. Thank you, everybody.
Yeah, I don't know if Kathy, could they hear you?
I think so.
Okay, I'll repeat it. If you could place your questions in the Q&A function, I'll work from the top down and do my best to answer as many as I can. The first question I see is, do you use Exparel? Exparel is a type of local anesthetic, so that's a numbing medication. It's advertised as a long-acting version of the numbing medication bupivacaine. I used this for about 6 months when it first came out around 2013, and really didn't find that it was very helpful. And that's been borne out now in the literature. The only studies that have been published that have been positive have been sponsored by the company, and most of the all the other non-sponsored studies have been neutral or negative on it. I switched from Exparel to a injection technique that utilizes a cocktail of medications shortly thereafter. I've been using it now for almost 7 years, which has been very effective, better than my experience with Exparel. I don't use nerve blocks because of that reason. And the major benefit is the technique I use provides anesthesia throughout the knee, but doesn't provide any paralysis of the muscle. So patients generally have very well controlled pain for the first 24 or so hours. And they're able to move right away with no weakness. How long does one of the implants last? Well, most implants we're quoting 90% greater than 90% survival rates at 20 years or more, which is pretty amazing. Like I said, Ford and Chevy can't tell you that with their cars and trucks. But so the longevity of the implants has been a major improvement. and also has led us to offer it to younger and younger patients because we're more and more confident that they're going to hopefully not have to have any additional operations. Is it possible to replace both hips at the same time? It is. And the criteria for that is, you need to have two problems. So you need to have two bad hips. Some patients are like, well, while you're in there, just do the other side, and that doesn't work. You need to be very healthy. It is a double dose of surgery. So we generally, these patients are younger and have minimal to no medical problems. And in my opinion, the other reason, you need to have a reason to have both done at the same time, because it is a little bit, it's a lot more surgery, and the risks are a little bit higher. The complication rate is slightly higher. So most of those people are younger patients that can't afford to miss time from work, sometimes international patients. Otherwise, it's a little bit safer to stage them, usually around 3 months apart, to allow patients' bodies to recover as well as their hip and leg before you do the other side. How many years does a replacement last? I think we already touched on that. Generally, we're shooting for over 20 years at this point, at least from a wear standpoint. There are other reasons implants can fail other than wearing out. Infection, fracture, sometimes the parts can loosen from the bone, but generally we don't see the plastics wearing out anymore, which is pretty amazing. How long is the recovery time for a hip replacement? It depends on the person, so there's a wide range. Obviously, younger folks tend to bounce back a little bit quicker than some of the older folks. That's probably a more individualized conversation, but most hip replacements now are done either outpatient, meaning they go home the same day, or they stay only one night. Occasionally, patients would need more than one night in the hospital. Most people are on a walker anywhere from a couple days to a week or two for balance purposes. Then they transition to a cane for about another week or so, and then eventually nothing. People that are still working, desk jobs are often back to work between 2 and 4 weeks after the operation. And people that work more physical jobs, it really depends, but more like 6 to 12 weeks if you're a laborer or have a very physical, high demand job. For most people, the hip replacement recovery is pleasantly quick, or surprisingly quick. Are there advances that are worth waiting 1 to 2 more years, assuming a patient can do that? Well, we're always having advances, and we're always having more and more data coming out. There's nothing on the horizon that looks like is going to be earth-shattering or drastically change the way we do hip or knee replacement at this point. What we're probably going to see is possibly more advances in robotics. There's a chance with knee replacement you could see the custom knee replacement combined with a robotic system. There's no sign that that's going to happen right now, but I could see that potentially happen in the next 5 years or 10 years. But there's nothing right now that would suggest that waiting is going to make a huge difference in the technologies or the procedures. How does the surgeon decide which device, or decide which type? I'm assuming, I'm not sure if they're talking about, that question's about implants or if it's approach. Implants is sometimes a discussion with the patient. Oftentimes the surgeon is choosing the implants based on how they will fit the patient. Often we can, especially with hips, we'll template the surgery ahead of time on a computer. We can go through different companies' implants and try to figure out which ones fit the bone the best. With knee replacement, there sometimes are discussions about robotics versus custom. Sometimes patients have strong preferences. At this point, all of the implants that are on the market from the major companies have good track records, and there's not, at this point, data that would suggest that one implant is significantly better than another. And so oftentimes it's just a discussion. Let's see here, 2 questions. Can you discuss advantages and disadvantages of partial and full knee replacement? So partial knee replacement is where we replace just one of the 3 compartments of the knee. The knee is made up of 3 compartments: the medial, lateral, and the kneecap compartment. They make implants that only replace each one of those individually. And so if a patient only has disease in one of those 3 compartments, partial replacement is an option. The benefit of partial replacement is that it generally it's a little bit quicker operation. Recovery is a little bit faster. The other thing is that we keep all of the ligaments in a partial replacement. So the ceiling's a little bit higher for a partial replacement, meaning a really good partial replacement will be more likely to feel natural and normal for patients than a full replacement. The downside is that you don't replace all of the knee. So if you have disease in other areas, or if you go on to develop arthritis in another area, you would likely need another operation converting the partial to a full replacement. We do know that partial replacements have a little bit higher revision risk or redo risk than total replacements. And so that's also a conversation to have with the surgeon. And if you see multiple surgeons, you may even get multiple answers on their opinions and philosophies around partials versus total. But those are the general pluses and minuses of those two. So I apologize. It says can only see the presenter, no graphics or pictures. I apologize if you couldn't see my talk. I hope that came through on the share screen function. Let's see here. So one question was specific to a person. They had screws put in their hip probably for a hip fracture a few months ago, and the question was, can you do a hip replacement after having screws in place? And the answer is yes. It really doesn't typically add much to the operation. We still can do it through an anterior approach. We still can do it through the same relatively small incision in the front. You just remove the screws as you're exposing the hip. There's a tiny risk or slightly higher risk of fracture during the operation, obviously, with some holes in the bone, but generally they proceed and almost behave as if as a first-time replacement. There's a general question about what's the criteria for either hip or knee replacement. I think that's more or less a question about when do patients decide to move forward? When is the time to do it? And that's a very individualized question. It really is not typically or should not be the surgeon telling the patient that that they need a replacement. It's really the patient asking the surgeon. The way I phrase it is most patients will ultimately know. They'll know when their hip or their knee is significantly limiting their lifestyle, such that they want to improve. Sometimes it's that they can't do the things that they want to do. They can't, exercise or have to think twice about walking, distances, or they have a hard time getting out of chairs. But for everybody, that's different, and that's a conversation you should have with your surgeon to really think through that. So one of the questions is about, I've been told my hip needs to be replaced even though my knee is where the pain is. So how do you determine that? Hips are interesting in the sense that sometimes hip pain or hip arthritis can present only with knee pain, and it has to do with how the hip is innervated. Usually we can tease that out with X-rays. We also can inject the hip sometimes with numbing medication, local anesthetic, and if patients, obviously if your knee pain goes away with a hip injection, then the problem really is in the hip, and I've definitely seen that. It's not a very uncommon situation to be in, but that's something we usually would tease out again before the operation or before picking the right treatment option. Another question about someone who's 68. They have family that lives a long time, and are they a good candidate for replacement? And again, the materials that we're dealing with these days, we're not seeing them wear out at the same, really not at all at the same rate. And so age is less of a factor. The way I see it is there's no reason to withhold the cure if it's the right thing for you based on your age. And so I'm telling patients even in their 30s and 40s, if they have really bad disease, which it can happen that young sometimes, it's rare, but it does. Historically, they were told they needed to wait, or if they were going to have it done, they were going to have it redone. And that doesn't necessarily apply anymore. And so age is a consideration, but should not be the driving factor for replacements at this point. Are there preferred methods depending on the patient's age? There are some considerations. Like I said, on the hip side, often patients over 80, I will cement their femur component rather than wedge it in, just because there's a little bit higher risk of fracture during the operation if we do a press fit implant, lower risk of fracture with cement. Other than that, the techniques are age independent for the most part. Does the anterior hip replacement have any risk of infection or increased or decreased risk of infection? It does not. The infection rate is similar. One of the questions was, can you discuss re-replacement or revision replacement, or even converting a partial to a full knee replacement? We'll start with converting a partial replacement to a full knee replacement. Generally, they're a little bit more complicated than just doing a native first-time replacement. But most of the time, unless there's significant bone loss, which would be unusual, you can replace it with just standard implants. The plastic thickness might be a little bit thicker than someone that had never had anything done to their knee. But most of the time, you don't have to do special techniques. You would be prepared to do those techniques at the time of surgery if needed. Redo replacements can vary wildly. I mean, you can have relatively straightforward redo replacements where you're changing just the plastic or one of the components and the bone quality is still really good, to very complicated reconstructions, and those would depend on the situation. One of the questions I had about a patient had really bad arthritis in their kneecap or patella. They had terrible pain going up and down stairs. The rest of the knee feels good. Can you get a partial replacement? And the short answer is yes. We would want to do, to examine that and possibly image it. But yes, they make partial replacements for the kneecap compartment, and they work very well when they're the right thing to do. And so we would just need to work that up and make sure that that's the right thing. But the short answer is yes. One of the questions is, if you live alone, do you have to go to rehab after surgery? Let me take a sip of. The short answer is no. There's been a big move away from rehab facilities over the last decade. They call them rehabs. In reality, they're nursing homes. We know that from multiple studies that patients' recoveries and outcomes are actually worse when they go to rehab facilities. So we do everything that we can at this point to get patients back home, and we have a lot of resources at our fingertips to allow patients to recover at home. Generally, if you live alone, it would be helpful to have some help, whether it's family or friends in the home, at least for the first few days after the operation. But we can send physical therapy out to the house. We even have private duty nursing services. We can make the situation work the vast majority of the time and keep people out of rehab facilities. What are the out-of-pocket costs to the patient for surgery? That's going to vary quite a bit depending on your insurance type and the plan, and that's really hard to go into. But we can usually give you a pretty good estimate based on your individual plan ahead of time, and the hospital and anesthesia group can do that as well. You should definitely have an idea. You would never go into the surgery not knowing what the cost would likely be on the back end. Is swimming okay after hip replacement, and how long? The answer is yes. Swimming is encouraged. I do ask patients to allow their incision to fully heal before they soak it in a pool or hot tub or bath. Typically, that's between 3 and 4 weeks after the operation, but you'd be able to do it at that point. There was a revision question. So about rehab facilities, one of the questions was whether or not you would stay overnight. And that if patients live alone and their resources are limited, yes, we typically would hold them in the night in the hospital overnight, and they would leave the next day or even the following day to give them a little bit more of a head start to recover at home. How do we know which knee replacement method we will get? Can we choose custom knee replacement? Is it covered by Medicare? Yes, all of the techniques at this point are covered by Medicare and insurance companies. The answer is you would know ahead of time. It's a conversation you would have with the surgeon, and you do have, the patients do have input in on that. We offer multiple techniques. Hopefully, as we gather data, maybe one technique will actually pan out to be better than others. Obviously, those would be the ones we would suggest. But yes, it would be a conversation on the front end, and you would know what you were getting. Someone wanted to know sort of the general post-operative recovery for a hip replacement, someone in their mid 60s, reasonably healthy. I think we touched on that. Most patients are either done outpatient, home the same day, or they stay typically one night. You're on a walker for a couple days to a week or so for balance purposes only. Once you're really steady on your feet, you transition to a cane for a week or so. And then once you're really steady, you would not have any assisted device. Most patients do about 2 weeks of in-home physical therapy with hip replacement. Hip replacement therapy is not complicated. Most of my healthy patients actually don't need any additional physical therapy after the first 2 weeks. You just got to get back into walking and using it and get back into life. Obviously, if someone needs it or is lagging behind, we'll order it. But most, I would say 90+% of patients do about 2 weeks in-home therapy and then just start getting back to it. One of the patients had a question about sleeping. It sounds like they get pain when they sleep on their side, but not when walking, and they want to know what that was. That probably is not arthritis. That's probably what we call bursitis. It's generally pretty easy to tease out with seeing somebody in person, seeing me in the office, and the treatments are very different for that. How long after hip surgery can you start power walking or on a treadmill? One of the other things I talk about with hip replacement, there are a lot of type A personalities in DC. I don't know if any of you people in the audience knew that, but I do ask patients to give me about 6 weeks on the recovery before they really start pushing it to avoid any setbacks. That allows the parts to grow in well. It allows the incision to mature. And so you'll be doing exercises, you'll be doing physical therapy, basic walking, but really pushing it on a treadmill or a bike or power walking or, quote, exercising for exercise. 6 weeks is a good time course to hold off until you start pushing it. What's the recovery time for a knee replacement? Knee replacements are generally a little bit slower than hip replacements. But not terribly different. Most healthy patients now are still done outpatient. Patients that are a little bit older or have some other reasons, health reasons or risks, they're generally in the hospital for 1 or 2 nights. Almost nobody goes to rehab anymore. You're on a walker again for 1 to 2 weeks, a cane for a week or 2. We do offer more physical therapy for the knees. They just need a little bit more work typically. Usually it's about 2 weeks of in-home therapy. And then you transition to somewhere between 2 and 4 weeks, maybe even up to 6 weeks of additional outpatient physical therapy for knees. So that's a little bit of a difference there. How long till I get back to normal activities with a knee replacement? Again, that's very individualized to the patient and their functional status, but usually, a healthy, active person between 2 and 3 months after replacement is starting to really, begin to hit their stride. You're going to continue recovering up to, honestly, 6 to even 12 months after the surgery help with the improvements. Another patient asked about, they're 64 years old, they have a torn meniscus and arthritis. They were told they needed to wait for a replacement. They had to give up a lot of things they wanted to do. And again, this goes back, that's really more of a, in my opinion, historic way to approach this. The reason patients were often told to wait or they were too young was the plastics. The plastics that were utilized in both hip and knee replacement would wear out. So if you look back at the 70s, 80s, and 90s, that was the primary reason that hip and knee replacements failed. And there's literature now that has compared that. One of the studies I published on hip replacement, and the methods of failure have changed, and we almost no longer see plastic wear as the problem. And to give people numbers, if you're a number person, the old plastics would wear at a rate of about 0.2 to 0.4 millimeters a year, which doesn't sound like much, but if you've got a 6 millimeter piece of plastic, you can kind of do the math, and 10 to 15 to 20 years down the road, you're kind of wearing the thing thin. The new plastics, like I mentioned earlier, wear at a rate of about 0.01 to 0.02 millimeters a year. It can be in your body 50 years, and we haven't worn a millimeter of the plastic away. And so I no longer, again, view age as a restriction. Age is a risk factor, in my opinion. So, if you're 20 years old and you've got a hip that has, fallen apart for whatever reason, I don't worry as much about them getting through the operation. I do worry about them hopefully not ever having another operation on their hip again, versus someone who's, 85 or 90 or age is, they're not going to wear the parts out, but, I got to make sure that, they have typically more medical issues, and we got to safely get them through the operation. So that's the way I think about age. But it's a discussion to have with your surgeon. Do you replace both knees at the same time? Very similar to hip replacements. Yes, we do. It's on a case-by-case basis. Again, it's a double dose of surgery is the way I think about it. It's a longer operation, more blood loss. The complication risk is slightly higher. But for some people, that does make sense. You need to be healthy. You need to have two issues. You need to have both knees need to be bad. And you need to have a reason to have both done at the same time. And again, those are people typically still working or traveling from distance, or in the case of knees, sometimes they have significant deformities of both knees, where if you straighten one leg and leave the other leg crooked, it can impair the recovery of the first knee, and sometimes that's a consideration. But that's definitely an individual discussion with the surgeon. How quickly can people walk upstairs after hip surgery? Well, we're sending patients home the same day in a lot of cases. So the answer is they can do it right away. And we often will, with our practice, we'll send a physical therapist out to your house prior to the operation. We found this to be very helpful. They do a home assessment. They'll talk to you about stairs and toilet seats and walkers and all the things that you're going to want to know about and practice and really be prepared to come home. This has really, really helped people a lot. Does Medicare pay for custom implants? We touched on it earlier. Yes, they do. At this stage, I don't anticipate that changing. Another question about having meniscus tears but no pain. Just because you have a meniscus tear doesn't mean that anything needs to be done about it. There are a lot of people walking around with meniscus tears out there that don't have symptoms, and so it's all based on your symptoms. The reason you would look at a knee replacement or surgery is typically for pain. It's typically a pain operation. Occasionally it's for functional deficits, but that's the way to think about it. You need to have pain bad enough you want to go through an operation to get better, is the way I think about it. Do any of the implants get recalled by the FDA? The FDA is constantly reassessing everything. They have post-market data analysis. If any issues come up and they're made aware, they certainly can recall implants at any time. The only one, the real significant one in the last number of years have been metal-on-metal replacements in the hip. There were also a series of replacements that had what are called modular necks. Again, these were popular really, around 2005 to 2010. Fortunately, we don't see them much anymore. They're not on the market anymore, but we don't even see them, patients coming in with them already implanted. How does osteoporosis affect hip replacement? Obviously, weaker bones, we worry a little bit more risk about fracture during the operation. If the osteoporosis is significant enough or the patient is old enough, again, I typically will cement those implants into the femur rather than wedge them in to try to minimize the risk of fracture. Do you have an opinion on stem cells or PRP? Specifically as it relates to arthritis, there's very little data out there that's of any reasonable quality. They're interesting concepts, and just so people know what stem cells are and PRP. PRP stands for platelet-rich plasma. Stem cells are cells that are thought to have the ability to become a different type of cell and possibly regenerate tissue. These fall under the category of what we call biologic injections. The way I think about it for something like arthritis, I'm guarded that they're going to pan out to be, significantly effective. At this stage, there's not a good mechanism for your own body to actually repair cartilage. So there's not a whole lot that these stem cells or plasma can augment or assist with arthritis. They probably are going to have more of a role with repairing tissues like Achilles tears or rotator cuffs or tendonitis and augmenting the body's ability to heal injuries. I'll be excited if they pan out, but I'm quite guarded at this time that they're gonna pan out. Is it possible to do knee replacement on older obese adults? The short answer is yes. We know that obesity is a significant risk factor for complications, and oftentimes we do our best to get patients to lose weight prior to the operation. It makes the surgery safer for a number of reasons. It makes it less likely that the implant would fail. There are some guidelines based on BMI that we use. It's not a hard and fast line in the sand, but it's something that you would have a conversation with your surgeon about. What is typical range of motion after knee replacement surgery? Can I kneel, squat, as I was when I was younger? A standard, like a native healthy knee without a replacement has about 140, 145 degrees of, range of motion was a lot. Generally, we try to shoot for patients to end up with about 120 or more of range of motion. Patients need about 110 or so to do just about all activities. They need to do like walk up and down stairs without issues. Most patients will achieve 120 degrees or sometimes even more. The therapy techniques are quite good. The protocols are quite good at this point. And so we just have patients really just follow, don't do too much, don't do too little. Can you kneel or squat? The answer is you're not restricted from it. I will tell you that a lot of knee replacements don't love kneeling or squatting afterwards. There was a recent study published where there was a desensitization technique where to try to make people more comfortable doing that. Patients are definitely allowed to afterwards. It's just whether or not they find it to be comfortable. My plumbers and electricians that spend a lot of time on their knees, I definitely have that conversation up front so they understand what to expect. What's the infection rate for hip and knee replacement? The infection rate is generally well under 1% when you look at all comers. Infection, though, is a little bit more complicated than that. It's rare to have infections develop in patients that are healthy and have no immunocompromise of any type. Most of the time, unfortunately, infections will happen in patients that have either are obese or malnourished or they're on immunosuppressive medication. They typically will have some risk factors that make them a little bit higher risk, but generally well under 1% when you look at all data. Ballroom dancing and knee replacement, worried about the twisting and torque on the replacement afterwards. Would the implant be able to handle that? The short answer is yes. There would be no restriction on ballroom dancing. I suspect that it would do fine. kind of working through some of the questions. Can hip replacement revision surgery be performed through an anterior approach? And the answer is generally yes. There are some situations where the posterior approach makes more sense if there are issues in the back of the hip that would be difficult to reach from the front. So it's an individual situation, but more than half of my redo replacements now are done from the front. So the answer is yes. What are the criteria for choosing a custom knee replacement? What if you had a standard off-the-shelf replacement on the other side? Depends a little bit. There's really not a criteria for choosing it. Patients, sometimes the concept resonates with patients. Like I said, I can't point to data yet that suggests that one implant type is significantly or even any better than another implant type. So it's really a personal choice, but the concept does resonate with a lot of people. If you had a good outcome on the other side with standard implants, if the surgeon is comfortable utilizing those implants, it might be reasonable to try to reproduce what you had. If for some reason you don't feel like you did as well on the other side, then maybe changing up the implants and using a custom knee would be another way to come at it. So again, it's something to talk about. Does total knee replacement result in a, quote, straightened leg? So a lot of patients who have knee arthritis either are bow-legged or knock-kneed, so to speak. We call that varus or valgus. The answer is yes. We ultimately will straighten the leg out in general. And that's one of the reasons I talked about redoing or doing both knees at the same time. If someone is tremendously bow-legged, if I straighten one knee out, then they have a period of 3 months waiting to do the other knee. There's a leg length discrepancy that is temporary. And so, yes, we do straighten the legs out. So there's a question about, I mentioned earlier about avoiding pools, hot tubs, things like that for usually about 3 to 4 weeks after the operation until the incision is fully healed. What happens when you leave the hospital? Are you able to shower? Are you able to do basic cleaning? The bandage that I use for virtually all replacements now is waterproof. I mean, it's the little things in the hip and knee replacements that make the experience so much better than it used to be. And it's not a small thing to want to be able to shower. And so the vast majority of people will have a waterproof bandage that stays in place for almost 2 weeks. And so you can actually shower, which is really nice for people. Let's see here. There's a lot of good questions. I think I might have gotten to most of them. Let's see here. Can you do yoga after a knee replacement? Yes, there are no restrictions with that. Again, some patients don't love to kneel or squat, or they may find certain poses uncomfortable, just like, probably patients will find certain poses uncomfortable before surgery. But yeah, there's no restriction on trying it. You're certainly allowed to do it. Most patients are quite a bit better after a knee replacement from a pain standpoint. We'll find they'll be able to do more with yoga. How long can you drive after hip or knee replacement? There are some studies that have looked at this. It mainly has to do with how quickly you can regain your what's called braking time. Most patients, that's at 2 weeks that patients will have regained their braking time, but that varies for everybody. Most patients will have permission at 2 weeks, but again, if you don't feel like you can drive at 2 weeks, you need to wait until you safely feel like you can do it. Do you accept referrals from any GP? Certainly, and happy to communicate with any primary care physicians. If you don't do hip surgery for a while, can you injure your good leg? Not typically. You know, the good leg will be doing more work, and you may find that it aches more. But as far as quote damage, you're not going to damage your good hip if you waited to do surgery on the right side. Now, sometimes it's rare, but there are some rapidly progressive forms of arthritis, especially in the hip, that can actually damage the bone. And that can sometimes make the surgery more difficult in the future. That's not common, but it's something that we can usually pick up on X-ray and make a recommendation on. Most of the time, you can wait if you're not up for it or if your symptoms are moderate. There's a question about in-person versus physical therapy at home after replacement. My protocol for most hips, again, they get in-home therapy just because it's more convenient for the first week to 10 days, maybe up to 2 weeks. A lot of those people are doing well enough, they don't need any more therapy, and they just do a home program on their own, which is nice. Knees typically start with some home therapy, and then we'll transition to outpatient therapy. Knees just need, the quadriceps needs to recover. Also, range of motion is sometimes more of an issue when you compare hips to knees. And so they'll just need more work done. The other thing to remember, like I said, the 6-week mark, there's no extra credit on the recovery. There's no way to speed the healing, you know, so you have to take it at the pace that the therapist is putting you through. You don't want to overdo it, but on the opposite is true. You don't want to be sitting around doing nothing. Would you recommend knee replacements in a healthy, active 90-year-old? Again, age, you know, there are a lot of questions about age. Age is a risk factor, you know, like I even touched on. Certainly patients who are 90 and healthy, they have, you know, substantial life expectancies at this point. And so if they're significantly debilitated from their knee pain and are healthy enough to do well with an operation, it's certainly a consideration, but definitely a discussion to have with the surgeon and really hone in on your individual situation. How do you address a leg length difference at the same time as hip replacement? Well, there are different reasons to have leg length discrepancies. Sometimes they can actually come from the segment, you know, from the hip itself. If the patient is long or short on one of their hips because of the hip part, we can adjust the leg length at the time of the operation. And with the technique I use with X-ray, I'm actually measuring the leg lengths, at least from the hip component, during the operation, which makes it you know, pretty accurate typically. Sometimes leg length discrepancies are not coming from the hip. They're coming from the spine. They're coming from farther down in the femur or lower leg. Those you can't, obviously you're not operating on that part, so you can't adjust the leg length much at that point. So kind of depends. It looks like that's all the questions I see. Let me see what time it is. Wow, we're at an hour. Well, I hope that was helpful for people. I'm happy to, you know, discuss anything in person with people going forward, and hopefully you found that useful. Feel free to reach out if you have any questions or make an appointment. Take care. Bye-bye.